Welcome to another very exciting episode of Tubules Live. Today we are very privileged to have Dr. Chris Sproat with us. Dr. Sproat is a consultant oral surgeon at Guy's and St Thomas's since 2008. He qualified from dentistry in 1990 and medicine in 1997 with an intercalated BSc in physiology. He's a clinical lead of a very busy department at Guy's, which has close links with the head and neck department and regional oncology department at Guy's and St Thomas's Foundation Trust. He has extensive experience with dealing with patients with osteonecrosis of the jaw, and he also has a specific interest in human disease in relation to dentistry. So, today's topic is bisphosphonates and bone anti-resorptive drugs, friend or foe. So without further ado, I'd now like to hand over the floor to Dr. Chris Sproat.
Thank you, Rena, for that kind introduction. Good evening and welcome to Tubules Live. My name's Chris Sproat. I'm one of the consultant oral surgeons at Guy's Hospital. And what I'd like to talk to you tonight about is bisphosphonates and bone anti-resorptive drugs. Are they our friend or are they our foe? But before I start, I would like to show you where we work. This is our department, this is our hospital at Guy's that has been recently reclad thanks to the Qatari royal family, which means that it will be still in existence till my retirement. This is our department on floor 23, and this is the view from the window of our operating theatre as I'm contemplating whether bisphosphonates are really our friend or foe. What I'd like to do today is discuss a bit of basic bone physiology, explain the benefits of anti-resorptive drugs, and discuss the proposed mechanisms of jaw osteonecrosis, and cover risk assessment for dental surgery in these patients, and hopefully increase awareness of new drugs. The objectives are to increase knowledge of bone anti-resorptive drugs and their benefits, understand the proposed mechanisms of osteonecrosis of the jaw, and improve assessment of your patients. So let's start with a bit of basic bone physiology. When you first look at bone, at the skeleton, it seems macroscopically static, but in reality, the skeleton is extremely dynamic, and believe it or not, the whole cancellous surface of your skeleton is replaced every 2 years. This occurs in a number of stages. There is an activation phase when osteoclasts are recruited from the circulation. Osteoclasts then resorb the bone during the resorptive phase. Then there is a reversal as we move into bone deposition, and the osteoblasts take over and form new bone. There is then a quiescent phase, and the bone then goes into a stable state. This allows change in shape of the bones, it allows adaptation to biomechanical forces and removal of micro damage within the bone. This maintains the bone strength and also can be used to maintain mineral homeostasis. This remodelling process may be targeted or non-targeted, and this is under either local control in degrees of targeted bone control or systemic regulation when it's non-targeted. Bone remodelling compartments form within the bone, and these are a specialised vascular structure that allows bone to be remodelled. The problem with these is they are also an ideal environment for bone metastases to seed. This shows a diagram of a bone remodelling unit, and what you can see here at the lead of the unit is the osteoclasts, and they eat their way through the original bone, and following behind are the osteoblasts, which lay down new bone, filling up the hole created by the osteoclasts. This can be directed by the osteocytes within bone. So if there are microfractures in the bone, the osteoclasts will head towards these microfractures and automatically repair the area with the osteoclasts laying down new bone behind. This diagram gives a more schematic view of the process, which is going on in you and I every minute of the day. What's special about the alveolar bone? Its function is to support teeth. It has an extremely high turnover rate. This is about 5 to 10 times that of the tibia or the femur. It is also perforated by the teeth which it supports, which pass through the mucosa, connecting it to an extremely hostile environment which is full of microorganisms. This is also a highly vascular area of bone, with the maxilla being more vascular than the mandible. If we talk a little bit about bone pathology, we will all remember osteoporosis. This is where there is low bone mass and deterioration of bone quality. This affects all of us. In our junior years, we have an excess of laying down of new bone and a small amount of resorption. As we become older, the bone resorption comes to dominate, and this is when osteoporosis develops. This process, though, can be increased by drugs like steroids and lack of activity. The problem with osteoporosis is it leads to fragility of the bone and susceptibility to fractures. And approximately 2 million UK women currently have osteoporosis, and there are over 18,000 osteoporotic fractures per year. Many of these fractures are a pre-terminal event, with 25% of patients who have a hip fracture, for example, failing to recover from this injury. This diagram gives a schematic of what osteoporotic bone looks like, and as you can see, compared to normal bone, there is decreased density of the bone structure, which makes the bone much weaker than in the normal situation. 1 in 10 women with osteoporosis will suffer a skeletal event, and as I said earlier, this may well lead to death. Bone anti-resorptive treatments with bisphosphonates and other anti-resorptive drugs slow down this process and can prevent approximately 50% of these skeletal events occurring. However, long-term use of anti-resorptive drugs will make the bone become more brittle, and there is increasing evidence that overuse of these drugs may actually lead to fractures as the bones are not able to stand the sudden impacts. And there is new thinking that bisphosphonates may only need to be used for approximately 5 years of duration.